Assalamu alaikum. Welcome back to our last two lectures with our moderators, Dr. Abbas Ma'rafi, Dr. Alia Hussein, and Dr. Ahood Lataybi.
Assalamu alaikum. I'm very glad today to present to you Dr. Dalia Sana. She is a consultant family medicine and the head of the Serra Clinic. She is a well-known senior clinical lecturer, and she is a certified trainer and examiner in the Family Medicine Board, and she had a diploma in clinical diabetes from Leicester University. Welcome, Dr. Dalia.
Thank you, Dr. Alia. Good afternoon, everyone. I'll start my talk today talking about a relatively new, but actually not a new group of anti-diabetic medication, which are the GLP-1 receptor agonists and their role in the management of type 2 diagnosis. At the end of my lecture, I'm happy to answer you about the myth and misunderstanding of misusing this group of medication over the counter by many patients without prescription for other indication rather than diabetes. Briefly, everyone knows from the first day that Kuwait, among the 6 GCC countries, according to IDF statistic, having the first prevalence of diabetes, especially type 2, since almost 24%, representing 1/4 of Kuwait population from the Kuwaiti and expats, they are having diabetes. And it's relatively from not even the red, from the dark red zone, and this prevalence will be increased in the next 10 years. As we know from the NCD lecture, that the leading cause of death worldwide is cardiovascular diseases. This is not only worldwide, it's the main cause of death in Kuwait, representing more than 70% of all death causes in Kuwait in adult population, followed by cancer. So diabetes is the main risk factors of developing or death related to diabetes in patients with cardiovascular diseases. Patients with diabetes not only have increased mortality risk, but they are often even having a complication from microvascular complication to macrovascular complication, leading them having a poor quality of life. Not only this, they are even dealing with not only the announced one, the one with coronary heart disease, heart failure, peripheral artery, increased strokes, diabetic retinopathy, but thinking of the end stage of each of them. They may lost a feet or having amputation. They may end up with blindness or even having a dialysis. So imagine what quality of life they are having with having this chronic disease, which is diabetes. Having diabetes, the alarm is ringing. Since the expenditure of health in Kuwait, it's not only related to diabetes and expensive medication, especially the new classes of medication, but also to diabetes-related complication. Imagine the expenditure on this only disease. And we all know that controlling the disease, diabetes, it's worldwide and important for each diabetic patient. And we don't underestimate that every 1% reduction in the HbA1c reduce not only the all-cause mortality, but also reduce the risk of stroke, cataract, heart failure, sorry. Oh, sorry, how can I go back, sorry? Yes. MI, microvascular complication, amputation, and all-cause mortality. Now coming to, what are the challenges as healthcare providers, we face, why we are not able to this degree to control our patient and to take them to the zone of control? What are the challenges we are facing? Yes, the patient themselves have resistance. They are having many fears of something like fear of hypoglycemia, fear of injection. They don't want too much medication. But what are the other challenges we are facing? We are in the era that everyone is talking and working that we want to control the NCD in the GCC. Okay, we have the protocol. Everyone said we don't have for primary care. Now we have the protocol for the primary care, whether international or local protocols. What about the medication? Almost all the classes of anti-diabetic medication are available readily in the primary healthcare centers in Kuwait. All the classes almost are available medication. One or two minimally from each class are available. The protocols are available. Everyone is talking, we want to control, we want to prevent, we want to screen. But what's happened? Why we are not yet reaching the problem, why we are not yet reaching the control? The problem is not only in Kuwait, it's a worldwide problem that having patients to get control. Almost, this is the statistic of the UK. In the best center, they're claiming that they are doing the best diabetes controlled worldwide. Still, 40% of adults with type 2 diabetes in the United Kingdom, they are failed to achieve a controlled diabetes when setting a target of HbA1c below 7%. So imagine, it's not only a local problem, it's a worldwide problem. So what we can do to overcome this problem? Going back to the American Diabetes Association recommendation, this is a 2022. We should know our medication, and we should, as healthcare providers, especially dealing with diabetes patients, know what's emerging, what's new in the management of the diabetes care. From 2022 and back then, it was recommended from the first recommendation that whatever class or whatever risk the patient, whatever category of diabetic patient, the initial step of management is having a lifestyle and having a metformin as a first line, whatever the patient risk was. To start with metformin, it was the cornerstone of diabetes management in all over all the categories. Then they add on other medication. From this year, the same ADA recommendation has been changed. The statement of starting with metformin, it's not there anymore. Although they recommend to start with a healthy lifestyle, but they categorize the patient, you can see to the left side, if the patient is at having a risk of developing cardio-renal disease, whether established or increased risk, or whether this patient with diabetes, whether they are a new or not a new type 2 diabetes, and they are having obesity or weight related problems and they want to lose weight. So I'll take them one by one. So at the beginning, any new diabetic patient, or whether the patient, we should assess the patient risk. Is he's having a cardio-renal risk? And this has been defined due to three categories of having a cardiac. First of all, established atherosclerotic cardiovascular diseases, the definition has been varied widely from different recommendations, but almost all of them agreed that certain criteria, especially those who are having MI, and those who are having a stroke, and they having any revascularization procedure for whatever the cause, they are diagnosed or labeled as established cardiovascular disease. There is controversy, but they are still considering variability include condition مثل TIA, unstable angina, and mutations, symptomatic or asymptomatic coronary artery disease, like for example, stable angina. Whether we are labeling a patient with a stable angina as having atherosclerotic cardiovascular disease or no, based on this, you may say yes or you may say no with justification. This group of patients and the other group with increased risk of cardiovascular disease, there are different also definition worldwide. But let's say they agreed on the ADA recommendation that any patient age above 55 years and having 2 or more other cardiovascular risk beside being diabetes, like hypertension, dyslipidemia, obesity, microalbuminuria, blah, 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 any other tumor risk beside being diabetic and his age is above 55, this patient should be labeled as having a high risk of developing cardiovascular disease in the future. What the recommendation for two categories, whether I have established risk or increased risk? According to the ADA recommendation, this diabetic patient with fulfilling these criteria should be starting on two groups of medication, either or. It's either GLP-1 receptor agonist with the proven cardiovascular benefits, and we will come this. There are only 3 medications from the class of GLP-1 with proven cardiovascular benefits, or having SGLT2 with a proven cardiovascular benefit. If you decided to start a patient of any of these two, and the patient after, let's say, for the follow-up, after 3 years, not yet reaching a target of HbA1c you decided to reach, you add the other group you didn't start with. If you start, for example, on SGLT2, and after 3 months the patient is not reaching the control points, then you add the GLP-1 here. Let's come to heart failure. Diabetic patient at any stage or at time of diagnosis or later on, any time they develop heart failure, whether symptomatic or symptomatic, and if you screen them and do echo, whether the ejection fraction is reduced or preserved, they should be treated with a certain group of medication for their diabetes. According to ADA, it's preferably the SGLT2 class with the proven cardiovascular benefits. Okay, we finished from cardiac, it's clear. What about those patients with established diabetic kidney disease or chronic kidney disease in diabetic group? And this definition should be considered. We are not only focusing in the reduction of eGFR below 60. It's either reduction and or having an excretion of albuminuria, of ACR, albumin creatinine ratio of more than 3 milligram. So those category of patients, after starting on maximum tolerated dose of ARB or ACE, we should look after their diabetes. And the preferable medication here is either SGLT2 with the primary evidence of reducing CKD progression, or GLP-1 with the proven cardiovascular benefit if SGLT2 here, it's not tolerated. Okay? And again, if they didn't reach the target, they add the other one. So we see certain indication, whether here, if cardiac risk or renal, you can see certain indication where metformin, it's not anymore the first medication or monotherapy to start with. Okay, what other indication we should start with? We are looking for patients with diabetes and they are having a risk of obesity, and we are aiming to reduce the weight. You can see here, here they recommend, you can see this is the right one of the main paragraph of pharmacotherapy. If you are targeting the glycemia, you can see the efficacious or more effective drugs in reducing or lowering the HbA1c. And if you choose to lower the weight, they put certain classification of medication, how efficacious or how effective they are in reducing the weight. Let's see, your target here is to control the glucose or to reduce the HbA1c. What are the very high medication recommended by ADA to reduce the weight in diabetic patient? According to them, the very high one, it's either the dulaglutide, the one available in primary care. The dose available in Kuwait of dulaglutide, which is Trulicity, is 1.5. It's the therapeutic. Actually, the higher dose, it's from 3 mg and 4.5. We don't have at primary care these levels. So to consider it very high, we should dulaglutide at higher dose. Semaglutide, okay? Semaglutide, the one more available in the primary healthcare. Its brand name is Ozempic. And terzepatide, it's a GIP one. Okay? It's the Mounjaro. a very high one, and combination of oral or injectable GLP-1 with insulin. So these categories are very high effectively in reducing the HbA1c in patients with high weight. What are the high efficacious? GLP-1, not the mention, not dulaglutide, not semaglutide, not GIB1. The other one I don't mention here, for example, liraglutide. It is high, not very high in reducing the HbA1c. Metformin, it's a good choice here. SGLT2 here. Sulfonylurea with cautious, since sulfonylurea side effects may increase the weight. Okay, although it is effective in reducing the HbA1c, but should be careful about hypoglycemia and the risk of increasing the weight. And TZD, which is not too much available. The intermediate one is the DBB4 group. DBB4 group, from the, what we know also, they are weight neutral. They are not reducing the weight as a group or as a class. What about if you want, and we want to focus on reducing the weight? What are the very high one? Semaglutide, اللي هو under name, brand name of Ozempic, and terzepatide اللي هو GIP اللي available الحين ما أدري بالحكومة بس بالprivate. highly efficacious in reducing weight is dulaglutide اللي هو Trulicity, liraglutide. احنا الحين what we are talking here is managing the weight in diabetic patient. Careful, I'm not talking in managing weight in non-diabetic patient. So the one with high efficacy, dulaglutide, liraglutide, both are available at the primary healthcare center in Kuwait. Liraglutide under name of Victoza. The intermediate one, the other GLP not I mentioned, SGLT2, and the neutral one we can give DBP4 inhibitor and the metformin. Are they the only indication of starting GLP-1? No. I'll tell you, according to the recommendation, consider insulin, or preferably GLP-1 at newly diagnosed type 2 diabetes patient with certain criteria, or at any time of losing control and having something called metabolic decompensation or catatonic stage, where the patient is having symptoms of diabetes, polyuria, weight loss. At any time they are having a very high sugar above 16.7 or HbA1c above 10%. Those patients should be started on injectable medication. If you want to start a basal insulin, preferably start a GLP-1 if available or if feasible, or if not contraindicated to those patients, instead of starting them on insulin. So we can understand now that there are many indications. Not all the patients are the same. Some of them with low risk, some of them with high increased renal risk, and some of them with weight, and we need to lose weight. Some of them at a stage they need to be started on injectable medication. So there is no patient similar to others. Here's the table. So which class of medication, like for example, the GLP-1, you see which one with a proven cardiovascular benefit, which one is a neutral, which one is for renal benefits. Talking about the GLP-1 as a class, it has a multifactorial effect. It's not only targeting or in one organ of the body. It works on the GI. It affects the gastric emptying, make it slow, and affect the gastric motility. Also, it's at the level of liver, at the level of kidney, at the level of pancreas, increasing the insulin secretion and decreasing the glucagon. It works at the level of the brain to induce satiety, decrease the food intake. And it has also a proven cardiovascular benefit because it directly affects the vessels and the heart and the muscles. So these groups, this class medication works on multiple different organs of the body at the same time. Are there any proven cardiovascular outcome trials? Definitely. If the guidelines been changing every year, they are depending on the worldwide major trials to change them. If you can see the green, maybe هني اللايت الإضاءة مو مبينة إن في difference بين green والblue. certain group of studies those the one or depends on إنهم to change الguidelines تغيرت الguidelines because of these studies since they see the group of GLP-1 as a whole some of them have cardiovascular benefit other one ongoing study show neutral effects on the heart but none of them is harmful none of them has a negative cardiovascular outcomes okay so it's either with proven cardiovascular benefits or cardiovascular safe. This is the conclusion of this slide. The GLP-1, we can classify them to two classes based on how similar they are to human GLP-1. Since the GLP-1, it's a normal hormone found in everyone's GI tract. How similar they are to human. Human GLP-1 based therapy those the one more than 90% or even more ratio mimicking the human GLP-1. The other class in pink, they are the one exenatide-based therapies. They almost 50 to 60% similar to amino acid sequences of GLP of normal human. And some of them to be taken on weekly, monthly therapies. The one available or proven GLP-1 will pharmacokinetic profile to them. For example, you can see some of them to be taking twice daily, and some of them to be taking once daily, and some of them to be taking once weekly. So depending on the pharmacodynamic, their half-lives, and whatever, so they are to be taking. This is the slide of the injectable one. Exenatide to be taking, like for example, sub-Q injection twice daily under the name of Bayetta. Exenatide to be taken as sub-Q injection once daily. It's been introduced in Kuwait, but I don't think it's available in the market anymore. Liraglutide, it's a sub-Q injection to be taken once daily, and it's available in the primary healthcare under the name of Victoza. This is the Lira. The dulaglutide is sub-Q injection to be taken once weekly under the name of Trulicity. It's available at the primary healthcare, and most of those who are sitting at the diabetes clinic, I believe they do practice this medication. A semaglutide, also it's a sub-Q injection, and to be taken once weekly, and it's of proven cardiovascular benefit. It's not available in the primary healthcare. Inshallah, it will be available, but it's available at the private sector. Exenatide, it's the other class, not the human like GLP-1. Exenatide to be taken at once weekly regimen. It's under the name of Bidorian. So if the thing is, the patient who were reluctant of injectable medication, either because they have a fear of it is insulin or non-insulin, or because of needle phobia or whatever. I don't want insulin, I don't want anything injectable. I have a hectic life, I don't know where to put it. Well, I travel a lot, I cannot keep it cold all the time. An oral type of GLP-1 now available, and it's ready. You can see it is classified, it's a semaglutide, similar to injectable semaglutide, but the difference it has to be taken every day. It's 94% mimicking the human GLP-1. With difference only is the 3 sequence amino acids. How this been? It was like a dream to have something injectable to oral. It's all about the combination of the medication tablet. It's a tablet, not capsule. And the outer coat of it, it has a certain effect or benefit. Whenever taking on empty stomach, it releases the capsule of it, or the outer layer. It makes the acidity of the stomach less, which is more alkali. It helps the full absorption of the tablets. And this will take effect rapidly. After half an hour, this all be reversible. Temporarily, it will change the acidity of the stomach. It will be all readily absorbed. Surprisingly, only 1% absorption of this tablet will give the full benefit of GLP injectable 1 when compared to the higher doses of injectable GLP-1. Imagine the 1% only how it be changed. That's why this medication should be taken early in the morning to make sure that the stomach is fully empty. Half cup of water is enough for the oral GLP to be absorbed. And after the patient takes it, you stay away from food, medication for 30 minutes. Then after 30 minutes, everything will be totally reversible, even the acidity of the stomach. So the patient can have normal meal, normal fluid, and all the medication without interactions. خلاص, everything will be back normal after 30 minutes. The starting dose of the oral semaglutide, it's a 3 milligram. It's just the starting dose and should be given to يعني, one packet for 1 month. Then the therapeutic dose is 7 milligram. 7 milligram, most of the patient will get the benefit, whether cardiovascular benefit or diabetes control benefit at 7 milligram. If a need of to increase to 14, we may increase, but 7 usually it's enough. These studies are comparing monotherapy of semaglutide with other medications, especially the one like SGLT2 inhibitor, DPP4 inhibitor, and GLP-1. And endpoint, they are comparing it with different concentration of oral semaglutide. When compared to DPP4 inhibitor, oral semaglutide, forget about the starting dose, which is 3, which is nobody will depend or rely عليه, we've proven the benefits على the starting dose. Start from 7 milligram and above. When compared to sitagliptin, which is the sitagliptin, which is the most prescribed DPP4 inhibitor at the primary care level, under name of Januvia, it is more helpful and more efficacious in reducing the HbA1c and reducing the body weight when compared to oral sitagliptin in all the doses, 7 and 14 milligram. Not only this, but when we come to the safety, the most common GI side effects of the GLP-1, whether they are injectable or oral, it's the GI side effect from different variety, from nausea, vomiting, diarrhea, abdominal pain. It is a class effect. No matter whether it's injectable or oral, all the class have the same effect. And usually it goes with time and it has person-to-person variation. Definitely, the side effect is more than DPP4 group because DPP is not known to cause a GI disturbance. Comparing oral semaglutide to other most prescribed now, SGLT2, the one available at the مراكز الرعاية الصحية, which is the IMBA. And they want to change to see the effect on reducing the HbA1c, how effective it is, and when changing body weight. Surprisingly, it was more effective in reducing the weight and reducing the HbA1c. When it comes to GI side effects, yes. Similar to all other GLP-1, it is more having GI disturbance when compared to SGLT group because the group itself is not causing any GI disturbance. Here I come to the summary of the classes. Just know where you are. Not all the diabetic patients are the same. Look to the recent recommendation of the ADA and the local recommendation. It's always been like annually changing according to the international recommendation. And almost all the classes of anti-diabetic medication with a proven cardiovascular, with a proven renal, are available في مراكز الرعاية الصحية الأولية in Kuwait. Please use them wisely and use them effectively, and you always follow the recommendation and the guidelines. And think about the patient safety, whether cardiovascular, renal, or weight, and if it is a low risk patient, diabetes. And here I come to the end. Thank you very much.
Thank you a lot, Dr. Dalia, for this informative presentation.
Thank you.
We have a couple of questions from the audience. First question that we have is, can GLP-1 agonists be used for patients with pre-diabetes if they are not tolerating metformin?
if we go back to the recommendation, and there's difference between, yes, there are study done, but what the recommendation says according to ADA, since we want to follow guidelines and we want to follow all the pre-diabetes guidelines in all the clinic, it's not yet recommended to be used as pre-diabetic. There is a study of proven benefit. There are many studies, but to be used per se for pre-diabetes as indication, we don't yet recommend. Please, and the prescription information according to مراكز الرعاية الأولية, the patient should be diabetic. One of the criteria to be prescribed and to be signed by consultant of the head of the center. So not yet, we are not yet to this stage to be used at pre-diabetes.
I see. Okay, the next question asking about do we need a time gap when we're changing from one GLP-1 agonist to another one?
Usually changing from one GLP-1 to other, it's not common unless there is indication. If the patient, for example, develop a risk and you want to change from one with not having a proven cardiovascular or renal benefit to a one with having, the transient time, it's the transient between changing the one to other. If it is a daily, a 1 day, it's enough to wash it out. If it is weekly, you need a 1 week to wash it out from your body. But changing from one to other, it's not usually the scenario here, unless the patient have a new recommendation to use the cardiovascular benefit or renal.
Okay. The next question is, there is a role for GLP-1 in patient presenting with retinopathy?
Sorry?
Is there a role for GLP-1 patient? If there is a patient with the diabetes and he has retinopathy, will be benefit from using the GLP-1 for that?
في studies saying that it is there, but احنا the recommendation and the indication of using it ممكن, بس it is يعني ما في الحين indication واضح.
Okay. Our last question: can oral semaglutide be used for weight loss?
There are ongoing studies for oral semaglutide for weight loss in the non-diabetic patient, you mean?
Yes.
In non-diabetic patient, they are ongoing study, but it's not yet licensed to be used for weight loss reduction in non-diabetic patient, and there is no FDA approval to be used for weight loss in non-diabetic patient. Not yet.
Okay. Thank you.
Thank you very much.
Thank you, Dr. Dalia. And now Dr. Dina will come to the stage for a trophy for Dr. Dalia. Thank you.
It is my pleasure to present Dr. Nasser Al-Graini, Family Medicine and Geriatric Consultant. Dr. Al-Graini is running the geriatric clinic in Emiri and Kuwait Hospital. Dr. Nasser is specialized in geriatric, palliative care, and general practice in oncology at University of Ottawa. He finished his last fellowship in geriatric oncology by working in the older adult with cancer at the Princess Margaret Cancer Center. Dr. Nasser, you are welcome to start.
Assalamu alaikum. يعطيكم العافية. Thank you so much for the organizing committee for inviting me to present in this amazing conference of family physicians, and I'm really honored to be among my colleagues and my fellows in family medicine. I'm one of you, and it's really nice to meet you again in this wonderfully and beautifully organized conference. So I'm going to speak today, of course, about those objectives, about healthy aging, geriatric giants, history of geriatrics, and the CGA, of course, and the anticipatory care, which we all focus and we all practice in our clinics. This is a slide here. I think some of you, the audience, has already been seeing this in previous talks that I did for family practice. Usually, I present this as age should not be a limit for somebody to work and to be actively involved in the society, and even in high stressful job like being the medical advisor for the White House. So this is Anthony Fauci, who's a famous medical advisor for the White House for 5 consecutive administration, and his job was involving him starting working from the morning until late hours in the evening, and he is like in 80s when he was in that age. So age shouldn't be a limit for somebody to be working and working hard. And this is what we always hope. Everybody will be hopefully being aging in the same context, and hopefully also in the same financial also context. And this is what we call successful aging. So there is a 3 definition that I would like you to know about, which is successful aging. It's essentially healthy, successful aging, and exceptionally healthy. And the difference between all of those, or 3 types of aging, is that with essential, that somebody with no acute disease, no recent history of cancer, nor mortality, and well-controlled chronic disease. So there is chronic disease, but it's well-controlled. Successful aging, it will be free of chronic disease, continue to function well, into an old and physically and physically and cognitively, but exceptionally healthy. There is no medication, no chronic disease, and normotensive and normal body weight also. And this is what we are aiming with the geriatric medicine. And this is the principle of healthy age, healthy lifestyle for elderly patient. Or older adult, I was supposedly calling them an older adult rather than saying elderly. And this, as you can see, it's focusing on cognition, medication, falls, function, nutrition, mood, sleep, and also sedentary lifestyle. So this is the National Institute of Aging, which is fall under the U.S. Department of Health and Human Services. And this is a common myth that has been debunked by this institute about aging. And this is also, we have it in our culture and in our similar, the Gulf societies, in the European also context, and also in the North American. For example, older adults cannot learn new things, which is totally wrong. Adult adults should take it easy and avoid exercise, and so they don't get injured. And this is what we are doing also in our cultures, like for our elderly. لا اقعد لا تتحرك خل عنك خل نجيب لك سايق خل الصبي يشتغل بدالك. لا, that's totally wrong. If a family member has Alzheimer, you will have it. This is also totally wrong, and this is what I get in the clinic all the time with the families who bringing patients with dementias. They are saying, شلون أنا أحمي نفسي يعني شلون أنا ما يحوشني مثل حاش أبوي ولا حاش أمي شلون نحافظ على ذاكرتنا. So it's not necessarily that if somebody in the family having a dementia, it will be running in the family. This is only a small percentage of families that have hereditary dementia. Also, depression and loneliness are normal in older adults. This is totally wrong. This is not the case. It's the opposite way around. And lastly, older adults sleepless. الكل عنده اعتقاد لا كريال كبير ولا مرة كبيرة ما أكيد ما تنام يعني شنو الواحد متوقع منها. That's totally wrong. They sleep and they should have the same sleeping hours as in our age, from 6 to 8 hours. And we have also young adults who they sleep less hours than elderly or the older adults. So, and this is just an example. There is a huge list of those myths that have been already debunked by the Institute. But it's not always the case. It's not always healthy. This is an example for President Biden while he was campaigning for his first presidency. And as you can see here, he had a hairline fracture while he was walking his dog. And طبعا all of you see President Biden while he was falling from his bike, or he was like confused when he was taking the stand about after a speech or before taking a speech, or he was confused. So that was presenting super early before he was in the office. And this is what we call frailty, disability, or comorbidities. So frailty, this is the concept that I would like you to understand, is the first presentation, or what, as we call it, the tip of the iceberg, which is when old age suddenly will hit the older adults. And this is what we see in the clinic or the emergency department, or even as an inpatient context. إن كبير السن يدخل المستشفى وبعدين فجأة تدهور صحته. Most of my patients and their families say إن من بعد الكورونا دكتور أبوي والأمي بدأت تدهور صحتهم. Why? Because they were isolated, they were staying alone, they confuse their routine, they become less active, less functional, and this is what happens. This is what I call the tip of the iceberg. And usually what we see, and this is what we call the geriatric giants, usually the elderly will present with falls, immobility, depression, incontinence, vision and hearing impairment, bed ulcers. This is why we call them geriatric giants, and it's meaningly the common geriatric presentation. And this is themes from, or this concept also that I would like to present today is the chronological aging versus, or chronological age versus the physiological age. طبعا chronological age means اللي هو what you have in your birth certificate, عمرك بشهادة الميلاد, versus the functional age is what is really you can do in your age. يعني في ناس نلاقيهم عمره 50 سنة بس he looks older than his giving age, وفي ناس عمره 70 سنة but he looks younger. يعني نفس هذول the same age group but واحد athletes وواحد في nursing home with walker. ليش؟ Why? It's not إن واحد عمره 65 سنة صار باكر راح يصير خلاص elderly. لا. It's a spectrum. إن واحد يكون منفت بعدين يصير vulnerable بعدين يصير frail, and this is coming from physiology, diseases, cognition and function. This is just a brief definition about aging. And this is the physiology of aging. This is what we call hemostenosis, and this is يعني the reserve that we have. هني الواحد لما يكون صغير في reserve. He can handle stress like falls, he can handle infections, he can handle hospital admissions. But as we grow and grow and grow, with the simple stress, like يعني هني بس مجرد infection بسيط, change in a medication dose will tip you off. يعني واحد خذ جرعة غلط أو خذ دواء غلط أو إن he falls on the UTI, simple UTI, خلاص, he will be admitted and everything will be downfall from there. This is just to show the physiology of aging for the cardiovascular system, hematology, hepatobiliary. Even the voice will be changing. عشان كذي تشوف بعض المغنيين خلاص they will retire super early, giving you what they have from diseases or what medication they are taking. Just this is a brief history about geriatrics. This is the lady who organized and established the concept of geriatrics in modern medicine. Her name is Marjorie Warren, and she introduced a systemic assessment for complex older adults, which can lead to and which result in improvement. And she also confided the British Geriatric Society. And also she had a focus on nursing training, and this is what we are doing also in primary care, train nurses how to look after geriatrics, and we call them gerontology nursing. This is a different term, gerontology nurse. Gerontology, it's a science which study the aging process, and this involves nurse, gerontological nurse. طبعا the aim of the nurse, teaching those nurses, the nurses to look after the geriatric for patient care, to assist them with bathing, dressing, medication, also and also for their functionality, and also they can help us as a physicians for assessment. I would like to talk about our golden standard tool that we use in geriatric medicine, which is the CGA. CGA, it's a process of data gathering, assessment, set a plan, and then the last step is execute this plan and follow up with the plan among us as a physician, with the family, with the caregiver, and to follow up with also with other specialty who looks after the older adult. طبعا this is what typically we have as a we call it the multidisciplinary geriatric teams. And as you can see, طبعا nurse and physician, the cornerstone of that team. وهذول team again, as you can see, we need all those specialty to call it a full multidisciplinary geriatric team. ليش يعني شنو أهمية السي جي اي؟ ليش نقدر نقول سي جي اي مهم؟ هذا this is a high quality study. It's a meta-analysis. And you can see the number needed to treat is 17, and it shows in this could apply CGA. We could apply it في home visits, as we are now establishing في primary care, acute geriatric care units, في post hospital discharge لما الواحد يطلع من المستشفى. We should do CGA. We can do it in outpatient or even in inpatient. وهني also the importance, as you can see, in the number needed to treat with CGA is even more efficacious and more important من الوارفرين, أحسن من الACE, and أحسن من الstatin themselves. يعني we have يعني good high quality evidence, which is cheaper if you calculate it financially. شنو CGA, what we are assessing, and what are the tools that we are doing. This is the domains, the most or the important domains that we are assessing. comorbidities or multimorbidities, which is the past medical histories. طبعا قليل كل ما المريض يكبر أو aging, you can see that he have more than one comorbidity: diabetes, hypertension, hypothyroidism, dyslipidemia, atrial fibrillation, CHF, and the list will go on and on. طبعا the adverse event, this is those that are the adverse event of having multiple comorbidities. The second domain, we are assessing medication, or this is the most important thing. We call it the 5 M's: the mobility, medication, mind, the cognition, multi-complexity, and what's better for the patients. Medication optimization. We do the medication reconciliation. We try to stop the stoppables, continue what should we continue, and to adjust what we can adjust from the medication. And I'm sure that in كلكم بالعيادة you can see that there is contraindication between two medication, or إن المريض تو طالع من المستشفى ونسى ياخذ دواء، أو إنه قاعد ياخذ معطينا 2 statins بالمستشفى، معطينا ستاتين وهو عنده ستاتين في البيت، فقاعد ياخذ دبل دوزنج في the same group. So medication optimization or reconciliation should be done in every visit. And this is the risk group, and this is what could be we can risk for reconciled medication list. And this is what it could lead to, and this is what could be the bad outcomes for medication, or what we call it the polypharmacy. The tools that we can use, it's the American Society of the American Geriatric Society. We can use the Beers criteria. They have now a new version, it's 2022, which is established by Dr. Beers himself. And this is it have a list of medications that we can avoid in older adults. This is also another domain that we should also look after, or we should ask about the social history. when المريض ساكن، من ساكن معاه, what is his home setting, if there is home adoption devices at home. طبعا بالنسبة حق الناس اللي يسوي home visit, this is very important and very essential domain that to be assessed, as we call it the home safety assessment. We also assess the function and the functional capacity. طبعا هني اللي هو activity of daily living, which is the essential or basic, اللي هم bathing, toileting, showering, dressing, and this is the other activity of daily living, instrumental. طبعا هني وايد مهم to focus about إن من اللي يعطي الميديكيشن هو ياخذ بروحه ولا لا. الفاينانس, he can do finance by himself, can they use the devices, and they can drive. طبعا this is very important to ask about driving. This is only just to show the physiology of aging for the MSK, and this is how we can طبعا this is a very simple screening test you can do in your clinic, which is the time up to go. إنه في كرسي ينحط حق المريض يكون قاعد على arm chair يقوم مسافة مترين أو ثلاثة ويرجع مرة ثانية ويقعد. And you can calculate the time that he is doing. If it's slower than this cutoff, that will give you an indication that this patient is at risk of falls or there is sarcopenia or there is frailty. And this is the tool that I like to use. We are testing for three things. We are testing for balance, gait speed, and we testing for strength or chair stand test. طبعا التولز اللي انا اتكلم عنهم هني وانا using them is validated internally and externally, and we can use it even in our society. So it's validated in multiple studies. Falls, we should ask every patient in geriatric clinic about falls if he have any falls in the last 12 months. طبعا if the patient قال إنه have one fall, definitely he will have another fall or he have multiple falls. And keep in mind that falls always multifactorial. Nobody will had a fall from one single reason. This is why it's very important and it's considered to be a geriatric gent that patient who will fall will have multiple causing his falls. It's very costly to the system, and it can lead to very drastic outcomes. Please, every elder adult patient, you should ask about falls in every visit. This is just to show even the taste, and this is why when we are assessing the nutrition, the taste and the smell will be changing in older adults. And طبعا انتم راح تشوفون هالكلام عندكم وايد بالعياده انه ابوي ما ياكل امي ما تاكل ما ادري شو نسوي له شلون نزيد شهيته ما عندك حبوب فتح الشهيه شنو نعطيه عشان يفتح شهيته ما يرضى ياكل. It's not only one reason. There is so many different reasons that can lead to anorexia. So keep in mind that the physiological change can lead to anorexia. Could be also environmental. There is financial deficit, and we have that in Kuwait. And I came across multiple patients who didn't have enough finance to buy for them some food, even here in Kuwait. You should keep in mind the mood, sarcopenia, and the decreased physical activity. So it's a multifactorial thing. And this is also physiological change in the oropharynx, even the esophagus, the slower emptying, and even طبعا كلنا عارفين ان elder will have GERD. And because of the medication they are taking, they usually are in PPIs. So undernutrition is very common in geriatric practice, and people are having BMI less than 23 should be treated very aggressively. And this is just a quick tool that you can assess for malnutrition. Next domain is mood. We should ask about mood also. We have a very good screening questionnaire, which is the BHQ. It's well validated, and we are asking about interest and low mood. It is very sensitive, the BHQ2, as you can see, and then if it's positive, then we can go for the BHQ9. And by this tool, we can diagnose depression in an elderly adult. It's very common in the practice, and it should be assessed. Now, cognition, there is no evidence or good studies that tell us that we should ask about cognition every visit, but it's never harm to ask about memory every now and then, because as we age, the cognition and memory will be also decline. And this is a quick tool. If we spotted a positive in our questionnaire that there is a positive change in the cognition, and it's the mini-cog test. It's 5 minutes, could be done just 3 words assessment and clock drawing, which can give you more information about what's going on with the older adult. طبعا السؤال اللي احنا وايد نسأله هو خرف ولا الزهايمر ولا اثنينهم ولا شنو بالضبط؟ طبعا as you know, Alzheimer is the most common cause or the most common type of dementia. It's one of the dementias, but it's not the only dementia that we are facing in the practice. بالكويت هنا ترى عندنا wide Lewy body dementia. We have vascular dementia because of the cardiovascular diseases that we are having. Also عندنا بالكويت ترى اللي هو الفرنتو تمبورال ديمنشيا. I'm sure كلكم دريتوا عنه اللي هو الممثل بروس ويلس اللي هو يمثل داي هارد المعروف عنه. عنده فرنتو تمبورال dementia. And I've seen in my practice a couple of patients that have frontotemporal dementia, and this is can see in the younger population. And there is other rare cause of dementia, but this is the most common cause of dementia that we are seeing here in Kuwait. It's Alzheimer or vascular, or could be mixed. And as you can see, dementia can affect all those domains. So it's a difficult disease. This picture is being drawn by a physician who had a Lewy body dementia. هذا الهلوسينيشن اللي كان يشوفه دكتور في لوي بودي ديمنشيا، وهذا اللي كان يشوفه. بس طبعا الهلوسينيشن ما راح تكون دائما كذي بليزنت، يوجوالي تكون تيرفاينج. هذول الناس اللي يكون عندهم يو تي ايز ولا يكون عندهم chest انفكشن او تشينج ميديكيشن، طبعا يكون فيهم اوريدي ديمنشيا يشوفون هلوسينيشن، ودائما الهلوسينيشن تكون مرعبه. فتلاقي دائما المريض بس يحرك يدينه بيشيل وايرات او بيشيل دريبس ولا بيشيل يحار او يعني كومباتيف، ما يبي الكير لان اللي فيه اللي يشوفه وايد يخوف. So we should be thoughtful about the hallucination and the delirium. طبعا this is just to review also domains that we should also ask about the pain, fatigue. طبعا fatigue لما نقول fatigue tiredness ان الواحد ما يقدر يسوي اللي هو ال ADLs وال IADLs. The sleep also we should ask about sleep, and the best advice is sleep hygiene we can offer for the patient. Sleeping. طبعا quality of sleep could be changed for elderly adult, but we don't usually need to use the sleeping aids for the elderly. And also sleep, also a multi-factor thing, and it could be affected by so many causes. And this is also just to talk about constipation, which is a very common presentation. And also, I just want to hint about the incontinence in the geriatric population. Hearing, vision also need to be asked about and looked after. And this is just to show you the immunization needed for the elderly. And this is done as anticipated care. And we have it in our primary care system in the geriatric clinic. It's already in the system, and this is what we need to ask about as an anticipated care for the elderly. And this is what we are aiming to have a healthy aging and a healthy lifestyle. طبعا هذا يمكن شفتوه من قبل، انا قايله انه شوف شلون كان الاعمار قبل. هذا من ديبارتمنت ستور في الستيت، انه كانوا يبيعون اللي هم هذول الفيتامينز حق اي واحد 35 اند ابوف. تشوف كان الجرياتريس كان اعمارهم قبل 35، بس الحمد لله الحين مع التطور العلمي يعني والمودرن ميديسن احنا وي كان يعني شيفت ذات تو 75. And if it's the stage for you for any questions.
Thanks a lot, Dr. Nasser, for this excellent presentation regarding geriatric. I have a personal question regarding the nutrition side for the nutrition thing about the elderly. Would you recommend to be use the supplement instead of the real food, like the Ensure to be used more, or you put the Ensure like any supplements above the food or the nutrition thing?
Excellent question. صراحة الانشور and the supplement doesn't add any wanted benefit, but we still can use them in a special context. Either the elder adult don't have any issues with the GI system, or he's not a cancer patient, or he's not in a systemic therapy. There is no added benefit of using Ensure or supplementation. But if somebody is being tested for like vitamin B12 or vitamin D, calcium, magnesium, if there is any deficiency, we can add that or can re-supplement that. But if somebody is having normal parameters, all those parameters, and he can chew, swallow, and can taste food, there is no dysgeuxia, there is no added benefit of the Ensure and the supplementation. And there was a recent systematic review done by the state, and they studied all the vitamins and the supplementation, and there was no good evidence to advise or with or against giving vitamins or supplementation, but they concluded that there is 4 vitamins should be cautious with recommending for elderly adult. Or I mean, the older adult is the vitamin C, because it can build up renal stones, carotene, it can cause hemorrhagic stroke. Vitamin C will calcium, it can cause cardiovascular event, and the vitamin E can cause lung cancer. So we should be careful with supplementation. It's not always the case that we need to use, but if we need, we can use, of course.
I see. Okay. Can the physiotherapy help in restoring the muscle power?
Yes, sure. Especially with patients with osteoporosis, patients with falls, patients with sarcopenia, they will benefit the most from physiotherapy. And we are focusing with physiotherapy about on the pelvic muscles and the pelvic extensors, because those are the muscles that will protect the older adult from falls. Definitely, and also we should focus in physiotherapy in balance and strength exercise. So if you want to refer somebody to physiotherapy, you should mention in the referral, we need to refer this for physiotherapy in the context of falls, of context of osteopenia or osteoarthritis, but we should mention that we are aiming for strength and balance exercise. So the physiotherapist will receive the older adult, he or she will know what to focus on.
Okay, and this is the last question. Are there early signs of Alzheimer in early age?
Early signs, yes. Depression. Depression could be the first introducing sign in Alzheimer patients. It could be preceding the Alzheimer, maybe 15 years before having the Alzheimer. It could be to that long. As if we don't have any testing that could predict who will be getting the Alzheimer and who will not, but definitely depression could be the first introducing sign for Alzheimer and Parkinson also. And then it will be just short-term memory defect, apraxia, anomia, اللي هو you cannot name things, we cannot do the usual function اللي هم الADLs. عشان كذا مركز على الADLs إنه ما بروح الحمام، وإنه يلخبط ما يعرف شلون يلبس ملابسه، أو إنه شلون يبي ياكل، أو إنه شلون يسمي الأشياء، يعني القلم ما يعرف يقول قلم، الأكل ما يعرف يقول اسم الأكل، أو إنه يبدي يضيع حتى بالأسامي. طبعا الأسامي لما نقول اللي هو الفيرست ديجري ريلاتيف، الزوج، الزوجة، الأولاد. So those could be the early signs that we usually should be aware of.
Okay. Thanks, Dr. Mansur.
Thank you so much for inviting me.
Thank you, our moderators, for your organizing the session. Please accept our token of appreciation. Dr. Abbas Ma'rafi. دكتورة عهود العتيبي. دكتورة علياء حسين.